It is my pleasure to introduce to you Dr. Antonio D'Alessio, which is a medical oncologist and clinical research fellow in the department in the Developmental Cancer Therapeutics Unit at the Imperial College in London. Dr. D'Alessio is an internationally recognized clinician scientist whose research focuses on liver cancer and cancer immunotherapy. His translational research combines innovative technologies, including spatial transcriptomics, circulating tumor DNA, and precision medicine in liver cancer. And he has played a leading role in the development of neoadjuvant immunotherapy for HCC, and was among the first researchers in Europe to present prospective data on the use of immune checkpoint inhibitors prior to liver surgery. So his contribution to the field have been recognized with multiple prestigious awards, including the three consecutive ESCO Merit Awards and the ILCA Young Investigator Award. And today, Dr. D'Alessio will present Reimagining the Use of Immunotherapy in Early Stage HCC, where he will discuss the evolving role of immunotherapy in the management of early HCC stages. So, Dr. D'Alessio, thank you for your presence, and the podium is yours, and you can start sharing your presentation.
Perfect. Thank you so much for your kind introduction. Just to double check whether you can hear me well, you can see me well, and now hopefully you will also be able to see my slides well.
Yes, we can hear and see you well. Yeah.
Perfect. And this is my screen. Voila. See it. My presentation. Where is it? So perfect. So here we are. You can see my slides well, I guess.
Yes. Now,
perfect.
Yes, perfect.
So it is a great honor to be here as part of this series of seminars. And I mean, despite my affiliation in the UK, as you can tell from my accent, I'm definitely Italian, even if all my research career has been done here in the UK. So I'm really pleased to be invited by you guys in Trieste. And my pleasure to introduce you the topic on which I've been working for the past few years now, which is neoadjuvant immunotherapy and how to implement the use of immune checkpoint inhibitors to improve the chances of cure for patients with early stage HCC. And I've also decided to add a little subtitle to my presentation, which is A Tale of Shipwreck and Successes, and you will see why in a moment. These are my disclosures. So let's start with a quick background. So why should we use immunotherapy? Why are we even discussing the use of immunotherapy for patients undergoing resection? Well, the point is that as anyone working with patients with early stage HCC, everybody will be aware of the fact that patients after resection, even after an optimal resection, after a curative resection, well, these patients unfortunately experience recurrence, and this cancer relapsing up to 70% of cases in the first 5 years after liver surgery. And you can see here, I will add a pointer. Well, maybe you will be able to see my pointer here. You can see that the recurrence after resection happens in typical bimodal fashion. So with the first peak in the first year after resection, which is most likely due to the presence of micrometastases that were left in situ after resection, but also a second peak happens here around 4 or 5 years after resection. This happens especially for patients with underlying liver disease. So this is definitely a de novo carcinogenesis due to new clones of cancer being developed after resection. So definitely, we have to do something to improve the outcome of patients after resection, and we have tried to do that by using immunotherapy that already works in the field of patients with advanced disease. We are trying to incorporate immune checkpoint inhibitors in patients with earlier stage liver cancer. And we have tried to do that in 2 ways, because when we perform resection on the patients with HCC, we can use immunotherapy either before or after resection. Let's start to discuss the evidence existing regarding the use of immune checkpoint inhibitors after resection, so used as adjuvant therapy. And later we will cover also the use of neoadjuvant, so before resection. Let's start with adjuvants then. So let's go back. The reason why this talk is called a tale of shipwreck and success is that the use of systemic therapy in patients with early stage HCC has, let's say, has been characterized by failures and maybe some success we will see in a moment. And let's start with the first failure, I would say, in this field. And all oncologists and hepato oncologists in the call, we remember the results, the disappointing results of the first phase 3 study testing treatment in the adjuvant setting. In particular, that was a STORM trial. It was a phase 3 trial that tested the use of sorafenib. The use of sorafenib for up to 4 years after resection or radiofrequency ablation. You can see here that it was the first notable failure with sorafenib not improving recurrence-free survival compared to placebo. So definitely, we would call it as the first shipwreck in today's talk. So definitely a very heavy shipwreck, since more than 1,000 patients were randomized, and sorafenib definitely did not improve long-term survival outcomes for these patients. So we have tried again, but this time we have tried with immune checkpoint inhibitors. And this was the IMbravo50 trial. It was the first phase 3 trial reporting on the use of immunotherapy combination, in particular atezo-bev versus surveillance in patients at high risk of recurrence treated with resection or radiofrequency ablation. So you can see here that patients with high risk of recurrence and without extrahepatic disease or macrovascular invasion were randomized to receive up to 1 year of the combination of atezolizumab, which is an anti-PD-L1, versus the anti-angiogenic bevacizumab, randomized to receive this combination versus active surveillance, which is what we would do now in our standard of care. After resection, we just follow up these patients and with regular scans and blood tests. Primary endpoint was recurrence-free survival. And you can see here that there was a first readout of the trial. So if you go on PubMed and you Google and you search for IMbravo50, you will see this publication published on the Lancet showing that initially at the first readout, at the first follow-up point, this trial was initially positive, because you can see that the hazard ratio for recurrence-free survival showed an initial improvement in the atezo-bev arm compared to surveillance. However, you can see already that the shape of these curves is not really that convincing. And you can see that these two Kaplan-Meier curves for recurrence-free survival in the atezo-bev and the surveillance arm were starting to collide and to get dangerously close. And indeed, the overall survival at this first readout was not mature, but still raised some doubts, because you can see there was not clearly evidence of improvement in overall survival in the experimental arm with immunotherapy. And indeed, in the community, there were already some initial doubts about this trial, because yes, the trial was, that gave us some problems, because as we discussed in this editorial already last year, there were the data on overall survival were not mature, and there were some concerns regarding the inclusion of patients with VP1 and VP2 venous invasion, and also the high rate of adverse events in the atezo-bev arm compared to the surveillance arm raised some issue of really how we could implement adjuvant immunotherapy in this population. You can see here that 46% of patients experience any adverse event leading to a dose interruption of any of the study treatment atezo-bev. So definitely not a walk in the park. So you can tell that from these early signs of doubts and concerns regarding this trial, definitely the perfect storm was gathering, awaiting the more mature results. And indeed, you can see what happened. This is what happened just a couple of years later, when a more mature follow-up was reached, almost 3 years of median follow-up. And indeed, the evidence that initially atezo-bev could have improved recurrence-free survival was not confirmed. And at the more mature follow-up, recurrence-free survival was not dissimilar when comparing atezobev and active surveillance. As a ratio 0.90, definitely these two curves clearly are now coinciding. And so that's definitely a failure for adjuvant immunotherapy. So IMbravo 50 was a negative study, and indeed, there are other ongoing studies in the same setting. They're starting to read out, and they're starting to read out negative. You can see these are the first results of another phase 3 trial using pembrolizumab, so only an anti-PD-L1 in the adjuvant, anti-PD-1 in the adjuvant setting, where in the Keynote 937 and already read out early this year as negative. So if we didn't have much luck using immunotherapy as adjuvant, so after resection, so why don't we try it in the neoadjuvant setting? And this is definitely my more field of expertise, and this is what I believe will be more promising in the next future for the treatment of these patients, because already there's a lot, as you can tell, a lot of clinical trials which reported, these are early phase clinical trials, phase 1, phase 2, reporting on the safety and feasibility of using immune checkpoint inhibitors before resection. And this does not come as a surprise, because if we use immunotherapy, immune checkpoint inhibitors before resection, then we can use the presence of the cancer in situ to ensure that there's a continuous release of tumor epitopes and a more profound expansion of the anti-cancer T cell pool, which, as you can tell from this very nice figure, which basically enhances a long-term sort of immunity, let's call it like that, a long-term anti-cancer response that can stay in situ even after resection and that can target the potential presence of micrometastasis. So improving the long-term survival outcomes in these patients. While if we give immunotherapy here in the adjuvant setting, so after that there's been a resection and immune checkpoint inhibitors are given without the tumor in situ, definitely the expansion of the T cell pool is less significant. And apart from the preclinical rationale, we know that there's also strong clinical rationale in other cancer types supporting the use of neoadjuvant immunotherapy compared to adjuvant. This is a phase 3 study in melanoma. So these are patients with resected melanoma. And you can tell that patients receiving a course of immunotherapy, immune checkpoint inhibitors before resection, and then continuing with immunotherapy after resection as adjuvant, had a significantly longer event-free survival when compared to the adjuvant-only group. The problem is that there are some definitions that we have to agree on, because yes, neoadjuvant immunotherapy is the strategy of giving immune checkpoint inhibitors before resection, but there's neoadjuvant and neoadjuvant. This is an umbrella term, and it's really important in clinical trial design to agree on a few definitions, because we could potentially use immunotherapy in patients who are upfront resectable. So patients who could go to surgery the day after, they have resectable HCC, but then we use immunotherapy as a sort of bridging approach. So we give a short course of immune checkpoint inhibitors with the aim of having a reduction on the long term of the recurrence rate. And this was done in the only phase 3 trial that has been published so far, and I will discuss that in a moment. So in this trial, patients with resectable HCC were enrolled. The problem is that, as you may imagine, it's really difficult to standardize the definition of resectable, because if you talk with surgeons operating in East Asia, or if you talk with surgeons operating in Europe, they will have very different criteria to define what resectable is. And it's really important when now we are going to move towards phase 3 trial design. As an alternative, since immune checkpoint inhibitor combinations are achieving more and more response rates and more significant tumor shrinkage in this population, then we could think of using immune checkpoint inhibitors as a sort of downstaging approach in patients who have sort of locally advanced HCC that are not resectable, that are, let's say, borderline resectable. They could become resectable if they undergo tumor shrinking with immune checkpoint inhibitors. And there are some trials investigating this. For example, there was the first phase 1 trial testing the combination of nivolumab plus cabozantinib in patients with locally advanced HCC and looking at the downstaging rate. However, it's really difficult to define potentially resectable. How do we define patients who are not resectable, but maybe could become resectable? It's really tricky because there are no standardized criteria to do this. And it is very tricky and challenging to design a clinical trial in this setting at this stage. And then finally, as any oncologist will be aware, now we are seeing in clinic more and more patients where immunotherapy combinations are started with, let's say, palliative intent. So they have advanced disease, multifocal, like not even locally advanced. It's proper advanced disease. We start immune checkpoint inhibitors with the palliative intent, but this patient falls in that minority of patients with a significant tumor shrinkage, with a remarkable response. And then in that case, we are talking about curative conversion. So some of these patients may be considered for resection at this stage. And this was tested in a clinical trial that I will also mention in further details in a moment, showing that adding surgery in patients achieving a curative conversion on atezo-bev could prolong survival. The problem is that these are exceptional cases, and again, very difficult to standardize. We will not know in advance if a patient started on a palliative intent will respond so well that then will undergo surgery. So tricky to design a trial in this setting. And now I will mention a couple of trials that are redefining the field, and that basically they will help us reimagining, as the title of my talk, reimagining the use of immunotherapy for early stage HCC. And this is a seminal trial that was published end of last year in 2025, and that was the first phase 3 trial reporting on the use of perioperative immunotherapy in resectable patients compared to surveillance alone. That's the CARES-009 study. Really important study where patients with resectable HCC, and be careful because resectable per Chinese criteria, this was a Chinese study. We know that surgeons in East Asia have different criteria to define what is resectable and what is not. So that's definitely a caveat that we have to take into consideration. However, patients with resectable HCC were randomized to receive 2 cycles of camrelizumab, which is an anti-PD-L1 plus rivoceranib, which is an oral anti-angiogenic agent. So 2 cycles before surgery and up to 1 year after surgery versus surveillance alone. You can see that the Kaplan-Meier curves now definitely separate very well compared to the adjuvant that we just saw before. And you can see here that the perioperative treatment significantly prolonged event-free survival. The median EFS was 42 months versus 19 months in the surgery alone. There are some caveats about this trial regarding the toxicity, but also regarding, I mean, we would not expect such a low event-free survival in patients treated with surgery alone. So probably this depends on the fact that some of these patients that were considered resectable per Chinese criteria, probably they had slightly more advanced disease that probably we would not consider for surgery in our centers. However, this is the first phase 3 high-level evidence on the use of perioperative immunotherapy in resectable patients, and that's definitely something that paved the way for future for the future of treatment of these patients. And then this is the other trial I wanted to discuss with you. This is the trial assessing the use of immunotherapy as a sort of curative conversion approach. Because in this trial, it was quite of a pragmatic trial that I really appreciated how this trial was designed, because basically these are all patients that we see in clinical practice. These are patients with microvascular infiltration, advanced disease, however, without extrahepatic spread, who receive atezo-bev, so the current standard of care treatment for advanced HCC. And then in case they achieve a partial response or they do not progress on atezo-bev, they were randomized to undergo surgery followed by atezo-bev for up to 1 year, or to just continue on systemic therapy. And you can tell that patients undergoing surgery had a significantly longer time to treatment failure. This is a reverse Kaplan-Meier curve, but the blue one goes better. You can see that the median time to treatment failure was 20 months versus 11 months when continuing with atezolizumab alone. And also in terms of overall survival, you can see an early improvement. So definitely you can tell that in this case, for the use of immunotherapy in the perioperative stage, we definitely have a brighter future ahead of us. So probably we are done with shipwrecks and we are heading towards more successes. And speaking of successes, I want to discuss with you my experience with neoadjuvant immunotherapy. This is the trial that I have coordinated in London at Imperial College together with David Pinato. This was the prime HCC trial. That was the very first European study, phase 1b study, assessing the use of nivolumab, so anti-PD-1 plus ipilimumab, given before surgery in patients with resectable HCC. So basically patients with the diagnosis of HCC are amenable to receive a biopsy before the start of the treatment. With resectable HCC and ineligible for transplantation, they underwent nivolumab plus ipilimumab on day 1, and then 3 weeks later they received nivolumab alone. And then after 3 weeks, they were restaged for radiological response and underwent resection and then follow-up for up to 2 years after surgery. Primary endpoint of the study was safety and feasibility. In particular, we looked at the risk of this treatment and of treatment-related adverse events leading to delays to surgery, because as you can imagine, that's the trickiest part of discussing this treatment approach with patients, because if a patient comes to me with resectable HCC, I have to discuss with them that they could go for surgery the day after, or within the waiting list of our surgical colleagues, but they have a disease that could undergo resection, and this resection can alone cure HCC. However, I propose them to undergo a trial where instead of going to surgery the day after, they receive 1.5 months of immunotherapy that is potentially toxic, that could potentially delay their surgery, with the risk that surgery is delayed or even canceled because of progression. And still patients agreed to undergo this trial, and that shows how important it is to involve patients in this discussion, especially around the risk of recurrence after surgery and the fact that we have to do something on top of surgery to try and improve our outcome. So these are the patients that we enrolled in the trial. These are 33 patients that were enrolled and received immunotherapy. 30 of them underwent liver resection, and that happened across 4 years, including 2 years of COVID that didn't help with the enrollment. And these are the baseline characteristics of these 33 patients. So most of these patients are male. They have liver cirrhosis in around 50% of patients, in 50% of them. It's a slightly lower percentage of patients with cirrhosis and liver cancer, but these are patients in clinical trials considered resectable, so definitely that explains the 50% of cirrhosis. Most of them, around 1/3 of them had viral-related HCC, and the rest were non-viral, including 24 with alcohol-related HCC, all child A, and these are the baseline characteristics of their tumor. This is in keeping with what we would consider resectable in a Western center. So single tumor, most of them around 4 centimeters in median diameter. Primary endpoint was safety, and the primary endpoint was met, because you can see here that after a median time of wait for surgery of around 2.4 months, only 2 patients experienced a delay to surgery due to a treatment-related adverse event. However, these patients eventually underwent resection without any issues. In terms of grading of the side effects, 76% of patients experience any grade treatment-related adverse event, including 9% with a grade 3 and no grade 4 or 5 adverse event was reported during the study. So definitely this is in keeping with a very short course on neoadjuvant immunotherapy, and that confirms what we were expecting from the literature available more in other cancer types. Let's move now to the efficacy results. Let's start with the radiological response. In the trial, you can see from this waterfall plot, 25% of patients achieved any grade of overall of radiological response, including one patient with a complete response. You can see it in green. Disease control rate was 97%. So basically just one patient had the disease progression during immunotherapy. However, this patient was found to have a combined HCC cholangio on the surgical specimen, and this patient, anyway, despite progression, underwent surgery. When using modified RECIST criteria, the overall response rate increased to 40%. And moving to pathological response, which is again another topic of interest of my research. I will cover that in a second. In this trial, we were able to evaluate 27 patients for pathological response, and 1 out of 3, so 33% of them, achieved a major pathological response. So you can see here how a pathological response looks like on histology. You can see this is basically the ghost of the tumor past, because this is where the tumor used to be before immunotherapy, and just after 2 cycles of immune checkpoint inhibitors, all the cancer bed is replaced entirely by necrosis. And this is how it looks like to the eyes of the surgeons on the macroscopic specimen. Moving to the survival outcomes in this cohort, median follow-up was 25 months, and 8 patients experienced relapses. Median overall survival and recurrence-free survival were not reached. However, the 1 and 2 year survival rates were, in terms of overall response rates, overall survival rates, 100% and 90% at 1 and 2 years, while for recurrence-free survival, 93 and 71% at 1 and 2 years, respectively. So, well, the point is that when you run a small trial like this one, yes, you are excited about clinical results, but if you are a translational scientist, then it's something that you want to use this trial as a platform to run experiments and to look for biomarkers of response. And particularly, we collected tumor tissues and blood samples before and after immunotherapy, so that we could study the longitudinal evolution of the tumor microenvironment and the peripheral immune phenotype before and after the treatment. And let's start with the tissue, right? So in terms of the studies that we conducted on the tissue, we did spatial transcriptomics with geomics and an imaging mass cytometry on the pre-treatment biopsy and the post-treatment resection. So before and after nivolumab and ipilimumab. You can see here that we selected regions of interest in the pre-treatment biopsy, and then we built the tissue microarrays on the surgical samples to then be able to perform these experiments on and optimize, of course, the requirement for the slides and optimize the cost with the TMA. In particular, the regions of interest in the TMA were collected from the tumor tissues and peritumor areas. Most of my findings, and what I think are the most interesting findings, especially from putting together the tumor microenvironment and the peripheral immune phenotype, regard the precursor exhausted T cells. So you may be familiar with this specific T cell subtype. That's a very exciting T cell subtype, even for us clinicians who understand little of immunology. But it's very interesting because there's a lot of growing evidence showing that immune checkpoint inhibitors do not really work here, do not really work on terminal exhausted T cells. They mostly work on these T cell subtypes that are in intermediate stage of exhaustion. They express TCF1, and they still have stem cell properties, and they are able to expand and proliferate upon the use of immune checkpoint blockade. And indeed, this is what we found in the pre-treatment biopsy. These are IMC imaging. you can see here that basically in patients who later responded to immunotherapy, we found a significant baseline enrichment of these precursor exhausted T cells, so CD8 positive, PD-1 positive, and TCF1 positive, while the non-responders were more enriched in exhausted T cell baseline. But where at baseline? Where? These are the spatial transcriptomic results. You can see that TPEX, so the progenitor exhausted T cells, were enriched in responders, specifically in the peritumor areas, where we found also a significant higher representation of the transcripts related to TPEX, so TCF7 and CD8. Moving to what happens after immunotherapy, so in the resection samples, you can see here that in patients who responded, we found a significant enrichment in these responding T cells, so CD8 positive, PD-1 positive, Ki67 positive, and let's keep in mind this responding T cell population because we will see it also in the periphery. And what is quite interesting also is that in patients non-responding, in the resection sample, we found an enrichment in immune suppressive cells, regulatory T cells, and terminally exhausted CD8 cells. And also you can see an increase in the resection sample of non-responders of a number of transcripts associated with immune suppression. PD-1, LAG3, COX, TIGIT, ions, but not of TCF7. So definitely we can see in non-responders that there's a gradually more immune suppressive microenvironment developing after immunotherapy. What happens in the periphery? Well, we analyzed with CyTOF, we analyzed paired samples of PBMCs before and after immunotherapy. We observed a strong induction of cycling Ki67 positive, CD8 positive T cells, and we observed a reduction in progenitor exhausted T cells and an increase in exhausted T cells. This is all samples without dividing in responders and non-responders. When looking specifically though, using a high-dimensional clustering approach and looking specifically at CD8 subpopulations, we saw, you can see here, this cluster 11, which is basically the same T-rest that we saw in the tumor microenvironment. This cluster 11 significantly increased in responders compared to non-responders. These are exactly the same cells that expand in the tumor microenvironment. As this subpopulation of T cells comes from the periphery and expands in responders, and it correlates with clinical response to immunotherapy. So our model basically is that the TPEX decrease, but they give rise to the responder T cells, and the clinical response to this shift is connected to the clinical benefit of patients responding to neoadjuvant immunotherapy. And then finally, we analyzed also circulating tumor DNA. We know how important it is to have non-invasive biomarkers of response, especially biomarkers that can tell us if after surgery, after resection, a patient is at higher risk of recurrence. We used a 20-gene tumor agnostic panel, so we didn't need to sequence the cancer. And at baseline, we detected circulating tumor DNA in around half of the population, and this percentage decreased after the end of immunotherapy and decreased after resection. However, and this is really interesting, all patients experiencing disease recurrence, when we measured the ctDNA, all of these patients had ctDNA detectable at disease relapse. And you can see that the presence of circulating tumor DNA after resection, in blue, directly correlated with the risk of recurring after 2 years, while patients without circulating tumor DNA, so without any evidence of minimal residual disease, had a significantly higher chance of being disease-free at 2 years. And you can tell also from these Kaplan-Meier curves that circulating tumor DNA acts as a non-invasive proxy for the risk of recurrence. And then I will finish this my talk with some future challenges, because yes, I have presented the current evidence, but how are we moving forward in this field? there are some open questions, and I'm happy to discuss some of that with you, because we start with endpoints. Because how do we assess, what is the best endpoint to assess the efficacy of this treatment? Of course, we would go for survival, right? But should we use recurrence-free survival? Should we use overall survival? There's pros and cons of both. For instance, if we use recurrence-free survival, we know that we have to wait less to have a readout. So this is a surrogate endpoint for overall survival. And it is not influenced by subsequent treatments. The problem is that we have seen it before. In BRAVO50, the only adjuvant trial reported, the only phase 3 trial with immunotherapy used as adjuvant was positive initially for recurrence-free survival, but that turned out negative later on. So definitely this is an endpoint that suffers from some bias. We could go for overall survival. However, there are some biases here too. The problem is that, yes, it is clinically meaningful. It's prioritized by agencies for approval. The problem is that it has a longer follow-up needed, and it is impacted by crossover. So as a potential alternative to this and to survival endpoints, we could decide to use pathological response. As I told you, I really believe in pathological response, and a big advocate. And I did some research on that. For instance, as also Luca was mentioning in introduction, we published the first evidence just now a couple of years ago already on the use of pathological response as biomarker of long-term survival outcomes for patients treated with neoadjuvant immunotherapy. Basically, this was our first experience showing that patients achieving major pathological response after neoadjuvant immunotherapy had a significantly longer recurrence-free survival when compared to patients without major pathological response. And this is really important because this was the first evidence, right? And it's really important because if we are moving now towards a setting where we are designing clinical trials for this population, we have to be careful on which endpoint we choose and which threshold of pathological response we use. Because in this experience that we published on Lancet Oncology, we demonstrated that 90% was the ideal threshold to assess pathological response. However, there are some other experiences like HERTZ-009, the other phase 3 trial, they used another threshold, 50%. However, they did also post-hoc analysis and they confirmed 90%. So if we do believe in our data, we have to use 90% to assess pathological response. And then another challenge, what do we do with adjuvant? Because we could tell that after immunotherapy in the neoadjuvant setting, so probably considering the negative results of BRAVO50, nobody should receive adjuvant. And also because we know that there's different patterns of recurrence after surgery. So giving adjuvant therapy to everyone, probably it's a bit indiscriminate. On the other side, we know that the HERTZ-009 trial, so the only phase 3 positive trial in this setting, used adjuvant for all patients. Also because adjuvant can target micrometastasis, and we can ensure that the patient can complete a full course of immunotherapy using that in the adjuvant setting. However, instead of going for these two, I would say, black and white approach, I believe that maybe we should personalize in our trials which patients receive adjuvant therapy. That's because we already have biomarkers that identify patients at higher risk of recurrence. We have circulating tumor DNA that we have just covered, and hopefully you will be able to see these results published in full shortly in the next few weeks, if the journal hurries up with the editorial review. So yeah, we know that patients with circulating tumor DNA after resection are at higher risk of recurrence. So probably these are the patients who benefit the most from adjuvant. But also maybe microvascular invasion. We know that there's a phase 2 trial showing that patients with microvascular infiltration on resection, they are at higher risk of recurrence. So probably these are the patients who benefit the most from an added course of adjuvant therapy. And then also we have just covered maybe pathological response can drive our decision making. And then I promise this is the last point that I want to cover with you. The real advantage of neoadjuvant trials is that these are the ideal platform to make good science because they allow us to collect paired samples before and after. And there's a lot of nice science that has already been published using neoadjuvant trials as platforms for biomarker of discovery. Here, I just presented a couple of examples of very brilliant papers published in this field. And so I do believe that there can't be neoadjuvant treatment without science. So in conclusion, we have seen that adjuvant immunotherapy does not improve recurrence-free survival following the negative results of the IMbravo50 trial, while neoadjuvant immunotherapy is here to stay, and the first phase 3 study, CARE-009, that was positive and that paved the way. However, trial design still has some challenges in terms of patient selection, adaptive design, the use of adjuvant therapy. And I do think that the future is bright for HCC because only if we are clever enough to use neoadjuvant trials for biomarker discovery, we can definitely improve the long-term outcomes for our patients. Thank you so much for your attention.
Thank you, Dr. D'Alessio.